Our next speaker is Dr. Daniel Spaite, and Dr. Spaite is a tenured professor and holds an endowed Virginia Piper Chair of Emergency Medicine at the University of Arizona College of Medicine. He's director of EMS research at the Arizona Emergency Medicine Research Center. He's published more than 100 original scientific articles, and I'll tell you, more important than the fact that he's published 100 articles is that he's published articles that are meaningful and impactful and change our understanding of the practice of medicine and EMS. I had the opportunity to hear him speak in Tucson, and really went. There are lots of publications or lectures that change your practice, but there are very few lectures that change the way you think about a problem. And my feeling after listening to Dr. Spaite speak was he changed the way that I thought about the problem. So rather than read the rest, I'm going to actually tell you that he received the Outstanding Contributions and Research Award from the American College of Emergency Medicine, which is the highest honor bestowed by the college for a researcher in the field of emergency medicine. And I am honored to have him speak with us today. Dr. Spaite.
Thanks. Well, I believe by looking at the faculty for the conference, I'm the only emergency physician that was invited, so that is a high honor. It's a privilege to be here.
Peter Reese called.
Yeah, thanks, Peter. I'm actually amazed 2/3 of you are still here. So this is the last lecture. Your chips and salsa are now redirecting blood flow to your mesenteric arteries and away from your cerebral arteries. Probably not a lot of you are involved in EMS and pre-hospital care. Certainly many of you aren't primarily focused on traumatic brain injury, but I do hope that this will be meaningful to every one of you because, thank you for that kind introduction. This really gets at how we think. And in fact, what we think we know versus what we really know. Much of what I talk about, the disclosure is it's funded by 2 R awards from the NIH. So the EPIC study, in brief, is the entire state of Arizona, the EMS system over 5 years is implementing the key components of the EMS traumatic brain injury guidelines, the national and international guidelines, which as you can see, focus on the 3 H-Bombs, preventing and aggressively treating hypoxemia, hypotension, and if the patient's intubated, preventing hyperventilation. Notice it's really massive. Now, if you have a major brain injury in the state of Arizona, you have a 93% chance that you will be cared for by EMS personnel who every single one of them is certified as an EPIC provider. There are over 600 EMS master trainers now in EPIC traumatic brain injury. More than 11,000 EMS providers have been trained. And at the end of the EPIC study, we believe we'll have more than 22,000 major brain injury patients in the study. And the primary findings, that is the impact of the implementation before versus after in the entire system, we hope to identify at the beginning of 2017. So it's a massive undertaking, incredible by 122 EMS agencies around the state of Arizona. So I want to I want to do this in such a way that it's a clinical question asked in a way that you find helpful. So here's the question. In TBI, what is hypotension? This is not a Kierkegaard question. This is really straightforward, but as you're going to see, it's not. So it's well known that even a single pre-hospital blood pressure of less than 90 in the setting of traumatic brain injury independently doubles mortality. It's really astonishing that a single pre-hospital identifier would have that powerful of an adjusted odds ratio for death as one single hypotensive event in TBI. And so the TBI guidelines for those age 10 and over are this. Basically, if it gets below 90, you give them a bolus of fluids and you then give adequate fluids to attempt to keep it at 90 or above. And the practical assumption that drives the entire concept of hypotension and traumatic brain injury is you're okay until you get really low. That's basically the concept. You don't do anything until you get really low. Now, this is, whatever you're doing, whatever matters to you, if you have evidence-based guidelines, I put those in quotes, be really careful. Because you know where 90 came from? It came from 200,000 normal American adults in their doctor's offices' blood pressures. They then made the bell curve for normal blood pressure for a US adult, and they said, fifth percentile sounds pretty low, plus it has a 0 on the end, because we couldn't do 88 or 93. God must have said it, 5%, 90, there it is. So that's where 90 came from, a normal population at the fifth percentile. And what's interesting is, because all the studies are small, we'll talk about that in just a minute, all of the studies dichotomize low versus not low. Okay, because the studies are between 50 and 250 cases, so they basically take low and not low, and they compare them. And what's interesting is if you actually look at the entire literature, they choose thresholds as low as 79 and as high as 110, and guess what? All of them find that it's better to be not low. So 90 simply comes from the fifth percentile of normal, plus most of the studies in the literature dichotomized at 90. The advantage to EPIC now is we now have by far and away the largest pre-hospital linked EMS TBI database in the world, probably by 2 orders of magnitude. So it's really, really powerful. So we took the pre-intervention group, because obviously in the intervention group, part of the intervention is treating hypotension. So we didn't want to bias this, and we looked at the pre-intervention group, and we looked at the patient's lowest blood pressure. So here's an example. We have, this is what's amazing about the EPIC study, we have every single documented blood pressure in the field linked to outcomes. So here's a patient whose lowest blood pressure was 122. That's how this person would have been entered into this analysis. And notice this, you ready for this? All of us thought, and if our thinking had been correct, something should happen around here, right? Where this risk of death goes like that, right? In other words, remember there's a threshold that you let them be hypotensive or you don't do anything until 90. So everyone kind of probably thought there's some point, maybe it was 85, maybe it was 95. But the reality is this line is absolutely straight between 40 and 120. And so let me put that into English and talk about a couple of other outcomes. Notice a victim with a lowest blood pressure of 110 compared to one with a lowest blood pressure of 100 has an 11% higher odds of surviving, 10% lower odds of ICU admission, 10% fewer ICU days, and 15% higher odds of going home as opposed to a skilled nursing facility. And what's astonishing is those odds are absolutely the same no matter which 10 group you compare across the entire 40 to 120. So it's just as true of 120 to 110 as it is from 70 to 60. So is there anything special about the 90 millimeter cutoff? And let me show you something. The reality is if they had had enough patients, here's what you find. Notice here, you can pick any threshold because we have so many patients in the EPIC study. You could pick 50, you can pick 70, you can pick 115, and actually if you take the patients across the entire spectrum, you can pick higher than that, and it doesn't matter which threshold you pick, it's always better to be higher than it is to be lower, no matter which threshold you take. And in fact, here's how astonishing it is. Here's mortality now, and this is an updated group that we just presented at the Resuscitation Congress in Orlando. And this is picking the threshold, you ready for this? Across the entire TBI population, this is picking the thresholds between 60 and 135. And notice the adjusted odds ratio, so this is adjusted for all the things that impact, all the identified things that impact survival. Notice here, so if you have a 1, it means that the group below and the group above are the same risk for death. So being to the right means that being higher is better than being lower. And notice here, and then we also have the 95% confidence intervals. So notice, until you get to 140, if you do it in increments of 5, every single one of these groups is statistically significant because we have 20,000 patients to look at now. It literally doesn't matter what threshold you pick. Nothing special about 90. Okay, so then let's ask the question from the opposite direction. What's the optimal blood pressure if you have a bad brain injury? And this is really striking. Notice, if you don't adjust, this is just simple blood pressure versus your risk of death. Amazingly enough, the optimal unadjusted lowest blood pressure, and remember this is the lowest pressure. If they had 10 blood pressures, their lowest blood pressure of 136 is actually the lowest risk for mortality in patients with TBI. And here's the really stunning, this is brand new stuff. This just got presented last week, so nobody else has seen it besides those there. And notice this. You see this incredible straight line that we talked about before, and amazingly enough, it goes to, sorry, I biffed that, but it goes to about 135, and then you essentially get a low, very large plateau of low risk for death between about 135 and 190. Who would have thought? And then, of course, over here, by the way, this is instructive, right? This side is what the blood pressure does to an injured brain. Right? The lower it gets, the worse it is for the brain. This side is what an injured brain that's dying does to the blood pressure. Right? So notice the two sides have a very different pathophysiology, but amazingly enough, this grouping in here, if you take this group, you have to get up to 135 before you actually find a quote equivalent threshold. So why has the literature missed this? I think it's a couple of things. First of all, as I talked about before, there are just the big studies before that have linked EMS data are 200 or 300 cases. They're just not large. And nobody's been looking for it. Everybody's been always asking the question in the literature, what's bad, what's low, what's hypotension? The reality is essentially no EMS studies have asked what's best. And then finally, we've certainly been enamored with permissive hypotension, right? The concept in permissive hypotension is that you want to just keep the patient alive until the patient who's actively bleeding, until the bleeding gets stopped. Interestingly enough, as probably most of you know, in the animal data and in the randomized human data, traumatic brain injury is always excluded from those cases. So the concept of low blood pressure isn't an issue until it's really low is probably not true if you add a traumatic brain injury to major trauma. So, notice the relationship between blood pressure and outcomes appears to be fundamentally continuous, not dichotomous, even though the literature has always treated it dichotomously. 90 may not be real. In fact, there may be no threshold per se, especially across the entire population. And clinically meaningful hypotension may occur at much higher levels than 90. So on the flip side, the optimal systolic pressure may actually be in a range rather than a target and much, much higher than any of us might have ever dreamed. Now, this is a key, especially at this time in the afternoon. Don't hear what I'm not saying. Okay, some of you will get that tomorrow, but don't hear what I'm not saying. This doesn't mean that we should go out and start treating everybody with TBI that has a blood pressure of less than 30, right? This is observational data. So you can't conclude that you should treat the patient to get up to, say, 130. That's not a conclusion, but it certainly may mean that 90 is way too low. That's a certain possibility from this level of data. And then finally, the last clinical question, in traumatic brain injury, are in-field trends in blood pressure associated with outcome? Otherwise, the serial blood pressures in the pre-hospital setting. We have no idea if it's better, if it's going up or if it's going down, or if it's not going either direction. Nobody knows that because nobody has had all of the pre-hospital blood pressures so that you can look at trends in serial blood pressure. So in the previous studies, to get very large ones, you have to look at the large trauma center-based databases. And you can find national databases, right, that have tens of thousands of cases. Well, if they happen to have a linkage to EMS, typically about 30 to 40% of them are missing the EMS data, so you have a selection bias issue. But more importantly, even if they do have EMS data, typically they only have a single blood pressure from the field. So you don't know whether the trauma registrar picked the first one, the last one, the highest, or the lowest. So the reality is we don't know what those previous linked studies mean. So we don't know about trends. So what we looked at was what happens if after you hit your low blood pressure in traumatic brain injury, what happens if you get increases after your low in the pre-hospital setting? Okay, so this is all EMS data. So just to make sure we're all talking the same language here, here's a person who had documented 7 EMS blood pressures in the EPIC database, and they had dropped to 80, but this person got up to 110 after they had hit their low or their nadir, okay? So this person then has an increase of 30 after the nadir of their blood pressure, okay? So having done that, we then grouped the patients into hypotensive, normotensive, mildly hypertensive, and severely hypertensive patients in these groups. So notice, here is the hypotensive group. Fascinating. Notice that, okay, so let me make sure everybody knows what we're talking about. So this is the probability, the adjusted probability of dying, so it's better to be lower on the graph. And this is an increase after the nadir of here's 20, and here's 40, and here's 60, and here's 80. Notice this, you get dramatic adjusted odds of dying if you get up to as much as an 80-point pre-hospital increase after your low if you were hypotensive at some point. Really striking. And in the normotensive group, this is also instructive. Notice that you basically, if you get increases after your low, you tend to get slight reductions. And notice, because of the huge numbers we have, these very, very tight 95% confidence intervals. And notice, the other thing is that's striking is if you get very large increases, it doesn't seem to be detrimental in people who started, quote, normotensive. Here's the mildly hypertensive group, and you'll notice 2 things. If you get really large increases when you started mildly hypertensive, if you get really large increases, your mortality goes up. But what's interesting is you don't start seeing that uptrend till you get above about an increase of 40, even in the mildly hypertensive patients. And then this is the severely hypertensive patients, and the bottom line is if you start out with traumatic brain injury and your first pre-hospital blood pressure is very hypertensive, then anything above that, after that, basically means you're dying of your brain injury, so you do much, much worse. So notice, these findings in the hypotensive and normotensive group support the concept of restoring and optimizing cerebral perfusion in the pre-hospital management of traumatic brain injury. So let me just finish with hey, I did faster than I expected. Aren't you impressed? Oh, yeah. Now I'll get even better introductions. He speaks shorter than he should. First of all, there may not be a special threshold for hypotension. Do you realize that goes contrary to every single TBI guideline that has ever been written for the resuscitation of traumatic brain injury? Second, the optimal systolic pressure must be maybe much higher than the current recommendation for treatment. Increases in systolic after the lowest pressure are beneficial in hypotensive patients and do not seem to harm normotensive patients. Now notice that is true statement whether we don't know yet whether it's treating to get them up there that improved them. We don't know that for sure because it's just observational. But nonetheless, this statement is true. It's way better to be higher if you have a TBI. The future may see higher targets for systolic pressure. And then what we really need is we need randomized controlled trials, but what the EPIC data has done now is it's now made it ethically viable to do randomized trials with much, much higher thresholds than anybody probably ever would have dreamed. Who would have dreamed that you probably should dichotomize 120 as a treatment threshold in traumatic brain injury? Nobody's ever been talking those kind of levels before. And then finally, and this is kind of the take home, even if you don't do TBI or EMS or TBI resuscitation early in the care, be wary of our assumptions, even when they're supported by decades of evidence-based guidelines. You look at every single study basically in the TBI literature that looks at hypotension, and essentially everyone assumes that there is some threshold, and the reality is it's probably a continuous risk adjustment measure and not dichotomous, probably functionally at any level. And then finally, always try to differentiate between what we think we know and what we actually know. My thanks, as always, to the incredible EMS agencies and fire departments in the state of Arizona. If it were not for them, we could not have quadrupled cardiac arrest survival in the last decade, which has happened in Arizona. Many of you have been involved in the in-hospital side of that incredible effort that's led by Ben Bobrow and the Department of Health Services in partnership with us. and then certainly this incredible implementation where 93% of the patients now get evidence-based, guideline-based, whether that's good or not, they get evidence-based, guideline-based care in the state of Arizona across a massive population. Thanks for the invite.